on our website, and I will try to be as clear as I can to indicate where we are on the agenda as we go through. I'm going to start with apologies and welcomes. I've got apologies from Keith Lloyd. I know that Steve has to leave at lunchtime, and I also have apologies from Andrew Jarrett, Jackie Davis, Judith Vincent. Do we have any declarations of interest on today's agenda? No, that's good, excellent. So I'm going to start, as we always start, with the patient's story. I'm going to hand over to Gareth to introduce it. So thank you very much indeed.
Thanks, Chair. Good morning, everyone. And can I introduce Kath Hart, my partner in crime this morning. Kath is the Deputy Nurse Director within the Mental Health and LD unit. We'll go to the table if it's okay, Kath. At the time the story was recorded, Viv, who is telling the story, was an inpatient at Callan Lan Detox Unit on his second week of alcohol detoxification treatment. Viv had been a professional musician most of his life and wanted to express his thanks to Callan Lan the only way he knew how, by writing a song. In Viv's words, I couldn't thank you all enough. I feel like this is my second chance. If it wasn't for you guys here in the ward and everyone in the Swansea office, I don't think I'd still be here. Now, the digital story highlights the importance and the value of detox ward. We support individuals with addiction who need an inpatient stay. And due to the level of demand for people requiring support for alcohol addiction and drug and alcohol services, I've developed a structured alcohol pathway to support individuals. Viv has had successful detox in Callan Lan and continues to remain abstinent and is moving on with his life. Now, the plan is we show the story and Kath and I are here to answer questions as well.
Thank you. Thank you very much, Gareth.
Hello everybody, my name's Viv Small. My close friends call me Val Sound. I'd like to talk about now my time detoxing because I'm an alcoholic, drinking sometimes up to 2.5 bottles of whiskey a day. It was time for change, I thought. That was 3 years ago, so now we've gone into detox after all this time. I feel a lot better in myself. I feel great. A lot of my pain is gone. I was having terrible stomach pains before I came in here. My legs are a bit stiff, but I am now 66 years of age now, and I've always been very, very busy. The staff have been nothing but wonderful here. Beautiful. I've written a song while I've been in here the last 2 weeks. It's a song about being old. The idea came to me about 6 months ago. It's probably the longest time I've ever spent writing a song, but having a little bit of time to myself in detox, I managed to finish it. And it goes something like this. The title is called My Get Up and Go Has Went. How do I know my youth is all spent when my get up and go has got up and went? But in spite of it all, I'm able to grin, thinking of where my get-up has been. Old age is golden, so I've heard you said, but sometime I wonder when I get out of bed. With my ear in a drawer and my teeth in a cup, my eyes on the table till I wake up. Asleep dims my eyes, I say to myself, is there anything else I should lay on the shelf? But I'm happy to say, as I close the door, my friends are the same, perhaps even more. When I was young, my slippers were red. I could kick my heels over my head. When I grew older, my slippers were blue, but I could still dance the whole night through. Now that I'm old, my slippers are black. I walk to the store and puff my way back. The reason I know my youth is all spent, my get up and go has got up and went. But I don't mind when I think with a grin of all the great places my get up has been. And once I'm retired from life's competition, my schedules are scheduled with complete reputation. I get up each morning and dust off my wits, pick up the paper and read the obits. If I see myself missing, I know I'm not dead, so I eat a good breakfast and go back to bed. Anyway, it's time to find a new pace now and turn the page on our new chapter. Thank you. Thank you everyone for listening.
Thank you. You said that would raise our spirits, and indeed it has. And it's lovely to see the impact that service has. That really very important service. So, are there any questions for Kath? And welcome to Kath. I should have said welcome to Kath to our board meeting. Nick.
Yeah, I just want to say fantastic story. It's certainly lifted us all this morning. But just wanted to know, like, what are the timeframes for people referring themselves? Is there like a big long waiting list? And what sort of support do they have long term then following the treatment?
So we've done a lot of work on our pathway into our alcohol detox service. We certainly did have a large waiting list, which is reduced. I don't have the exact figures on me now. It's something I can produce and find out if needed. But the pathway makes the access to the service more efficient. The detox unit, which is based in Neath Talbot Hospital, is only 5 beds, so it's not a large unit. And the average stay is 2 weeks, and they very much work on a recovery motivational model. So it's not just about the physical aspects of care, it's about the psychological aspects of care as well. And that continues then into discharge into the community through our community drugs and alcohol services. And it's one of the services in our service group really that is strong in partnership working with our third sector organisations. So the inpatient detox itself is 2 weeks. However, there's a pre-admission stage, and then the follow-up continues then into the community through our community drugs and alcohol services. And there's that in-reach as well, because they're all under the one umbrella. Although it's a small inpatient service, it comes under the umbrella of community drugs and alcohol services as a whole. So we've got that ability to in-reach and ensure that pathway is continuous. I hope that answers the question. Thank you.
Thank you. I would be interested to know what the waiting list is.
Okay,
I'll take that away. So if we can find that, I think that would be good. Any other questions? Yes, Louise.
How is it staffed? What sort of staff to patient ratio and who are the staff?
So we've got a mix of registered nursing staff and unregistered nursing staff. More recently, we reviewed the staffing on there because prior to COVID, it consisted of 1 registered and 1 healthcare support worker for 5 beds, 5 patients. We've reviewed it more recently and we've had an uplift. So we've got 2 registered nurses and 1 healthcare support worker through for the 5 beds per shift. We've also got investment for some physiotherapy input, occupational therapy input, and some psychology input. But that's a recent move post-COVID. During COVID, the unit did close, but it was an opportunity for us to pause really and to look at the service where we would want it to be. And so that investment came through the area planning board. So now we've got a very richer MDT approach to care delivered on that unit.
Thank you. Thank you very much, Kath. I'm not seeing any other hands. So thank you. Thank you very much for coming. Thank you for coming in person and for starting our board in such an uplifting way.
Thank you for inviting us and giving us the opportunity to share that. That's lovely.
Thank you. Thanks very much indeed. Excellent. So a couple of preliminary comments before we start. Firstly, I should have noticed when I had apologies and welcomes. This is Debbie's last public board meeting. We've announced Debbie's departure in a previous board meeting, but this is the last, your last meeting. We'll be very sorry to see you go. Debbie, that board members will have other opportunities to embarrass you further. Thanks, but you do leave us with the legacy of the people strategy, which is a really good a good way to bow out. And in the process, I think you brought the most immense dedication, counsel, and support, I think, to the board as a whole, as well as to the function of the Workforce and OD Director. So thank you for that. I'd also say my normal thing. So we've got a busy agenda as always, and we need to minimise the descriptions and maximise the discussion on the board agenda. So if I can just remind execs to be brief in their summary. If there are parts of the book, if there are parts of the paper that IMs haven't picked up on, we will absolutely ask the questions. But this is for debate this board, so that we can have that time. Excellent. Okay, so we're now going to receive and approve the minutes of the meetings. There are two sets to be approved. 30th of November. Apologies for that being so long. Claire apologised to me, but I couldn't see it getting any shorter. I think it reflects the length of that board meeting and the substance of what we discussed. But are there any comments, first of all, on accuracy? No. Any matters arising that we haven't picked up? No. Great. And then we also have minutes from the 14th of December, the special board meeting. Are there any comments on accuracy or any matters arising that we haven't picked up? No. So can I assume that the board members are happy for those to go into the record? Thank you. So we now have the action log. All open actions do have a status update. Is everybody content with where we are on that? Okay, fine. So my report provides an update on partners, independent member site visits, chair recruitment, and decisions made under chair's action. Board members are asked to note, and I'm happy to take any questions. No. Excellent, thank you very much. Can I ask all members to ratify the decisions made under chair's action? Great, thank you very much indeed. So we now move to the Chief Executive's report and to Richard.
Everybody. So at the start of the new year, we can anticipate in the depths of winter that the early part of the year always brings its challenges, and this year has been no different, with a number of things that I'll update you on. The first thing I wanted to say was that despite these challenges, my executive director colleagues and I, and our delivery group triumvirates, are committed to improving our services for the people that we serve, putting the patients at the centre of everything we do, and driving quality, safety and efficiency throughout our organisation. And that ethos will come through in terms of addressing some of the challenges that we face. And I think two things to highlight up front that have happened in the last few years. All house boards were informed last week by Welsh Government of their escalation status. That decision is informed by a tripartite meeting between Welsh Government, the Healthcare Inspectorate of Wales and Audit Wales. And whereas previously Swansea Bay University Health Board had been in what's called termed enhanced monitoring, the planned care, the cancer, the finance, planning, and maternity and neonatal services. As a result of the last tripartite meeting, the escalation status of the health board was increased to targeted intervention, which is one level higher than enhanced monitoring, specifically for performance and outcomes in terms of planned care, urgent care and cancer, and meanwhile planning and finance, maternity and neonatal services remain in enhanced monitoring. And although this is very disappointing for us as a health board to have that level of escalation, we do acknowledge the reasons for that. We recognise why that is the case. And actually this also reflects our own concerns about those ongoing challenges and what we need to do. And again, as I highlighted our determination, we will address them. The escalation relates to some of our long waits in planned care, some of our long waits in patients waiting for cancer care, and particularly our ambulance handover times at the front door. We will, during the agenda, I'm not going to go into the detail of those now, but it will be an opportunity to discuss those in more detail and the specific headings as we go through the agenda. And I would welcome comments and suggestions from board members as we do so, so that we have a good discussion about that. There are areas, however, we've been doing well. We've made great strides in improving the timeliness of treatment in many different areas. But we do need to recognise that we have to redouble our efforts and find sustainable solutions for those areas that have the greatest challenge. The second thing I think that was highlighted last week was a report from the Public Service Ombudsman for Wales, who issued a special interest report in relation to 3 patients from Swansea Bay and the way in which their appointments were managed, which resulted in them getting a delay in orthopaedic surgery. We've, as a health board, have accepted the Ombudsman recommendations in full. We've sincerely apologised to those 3 patients whose surgery was delayed and confirmed that all 3 have now had their operations. We are undergoing an assiduous check of our orthopaedic waiting list to make sure there are no other similar cases. Scrutinising those lists, but as well, we're putting in additional staff training to make sure the precise rules about referring to treatment times are followed as they should be. In most cases, the orthopaedic patients who waited the longest time for operation for those who are waiting for their surgery to be done at Morrison Hospital, because either the nature of that surgery or their coexistent medical conditions mean that they're at a higher risk of that surgery happening. And that means they need to be near an intensive care unit or a high dependency unit where they can be supported if necessary after their operation. We're recognising that, and that is why we've introduced launched the new orthopaedic theatre hub at Neath Talbot Hospital. We've ring-fenced 10 beds at Morrison for those complex patients. But importantly, we're also working with colleagues in Hywel Dda to identify opportunities for collaborative working across the border. That might in some cases mean that operations are done upon Swansea patients in Hywel Dda. It might be that we can accommodate some of our more straightforward cases that would have been done in Morrison are done in Hywel Dda, which frees up space in Morrison. That's an ongoing piece of work. But we did have some lists that operated before Christmas as a start of that project. We also recognise the need to keep people well while they're waiting for surgery, and patients who are waiting for joint replacement surgery are now able to access an exercise and lifestyle programme prior to surgery, which means they're far less likely to have their surgery postponed because they become unwell, things such as high blood pressure, but it also supports their recovery post-operatively, which means they've got a far better chance of recovering quickly. On emergency care, again, I think the detail of this we will cover largely within the agenda, but just to highlight a couple of things. I think demand hasn't slowed down over the winter as we would expect, but our challenges in emergency care have been compounded by high levels of infection in our hospital beds. There have been high levels of norovirus, Clostridium difficile, and the usual winter seasonal viruses. And we had to take that difficult decision to restrict visiting at Morrison Hospital from Wednesday the 3rd of January to what we call visiting with a purpose. In other words, visiting for patients who are at the end of life or for carers providing help and support for patients when they visit. We're now seeing a reduction in those infection rates, and so normal visiting arrangements were introduced from the 9th of January, apart from areas that we're seeing persistent infection levels as being high. We'll note, I'll say a few words about the strike action a little bit later, but I think in terms of those highlight areas, which is around the areas of escalation, so planned care, cancer, performance around emergency care, and then some of the other challenging areas around the orthopaedic waiting list. I'll keep the highlight of my report to those areas. I just wanted to take you through a few other things in the report. The Chief Exec's written report provides a lot of detail on these specific areas, but if I can draw your attention to a couple of things that aren't necessarily covered in today's agenda. The first of those being the Welsh Fertility Institute. There have been detailed discussions between the Health Board as the provider, with WISC as the commissioner, and with the HFEA, the Human Fertilisation and Embryology Authority, to address some of those concerns for the fertility unit. That's been led by Chris Morell as a director of therapies and health sciences. And we're all committed to putting this service on a sustainable footing. One of our challenges was the ability to find somebody to act as a person responsible for the service, the person who's formally responsible to the regulator for delivering the service in the way that the regulator requires. And I am very pleased to say that having had that challenge initially, we have now had 5 people step forward to sit the exams, to make them qualified to become the person responsible. And we're progressing with that urgently, so that we'll not only have a new person responsible, but actually be in a position to appoint 2, 1 for each licence that we hold, which will obviously give us arrangements for cover for leave and absence. The deep dive of that service review is underway to look at the constraints and risks, and I'm assured that Chris and the work that she has in training through that goal command mechanism is making great progress with that. Some of the options that we're looking at about the delivery of the service might require public engagement, and we're keeping clients up to date on these issues in parallel. The other thing I just wanted to highlight for you was at the industrial action from the 15th to the 17th of January, the first time, I think in Wales, there were 3 days of industrial action that were taken by GE in Wales. We were very pleased to be able to support the juniors in their right to exercise that industrial action. And we had a huge amount of support from our other clinical staff, consultants, specialty doctors, but also a wider group of staff who supported our services to make sure that we're able to maintain them and keep them safe. And although we did have to cancel some elective activity to make people available to do that, we did manage very successfully not only to keep our urgent services going, but actually to keep them operating exceptionally well during that time, despite there actually being no reduction in demand in that period. And then finally, just a couple of notable things at the end in terms of congratulations. I would recommend that you look at section 5.8 and look at the great work that's been done. And just to pull out 2 in particular, Dindy Gill, who was a former emergency department consultant at Morriston, and who led the development of the Wales Trauma Network, was recognised for his work in that in the New Year's Honours. And then secondly, just to draw out our digital services team, who won the Medi Wales Innovation Award for Technology and Digital Impact, recognising the success of the Health Board's Signal patient flow system, which has been adopted more widely. So congratulations to all of those that have been mentioned in there. I've just highlighted 2, but there are several others as well. And it's great to see that fantastic work has been done by colleagues. I will stop there. I think the rest is within, we can have a conversation on the rest within the body of the meeting. Thank you very much. Happy to take any questions.
Thank you. Thank you very much, Richard. Are there any questions for Richard? We've got the performance report later, and I know that independent members particularly have got questions around certain aspects of it. I'll leave it to you as to whether you want to raise those here or under the performance report. Thoughts? Yes, Nuria.
Just, I think for assurances, just a really general question, given that we're going to discuss the detail, which is around targeted intervention. These are the areas that have been concerning us for a while, so I think it's just that assurance that as a health board we have a roadmap as to how we will get out of targeted intervention. And that would be great for not just us, but the general public to hear.
Yes.
And I think the important thing with that was we're not waiting for something else to happen or for that process to start. We're already making advanced planning on what we need to look at in those areas to do immediately for ourselves. We will have a meeting with Welsh Government to understand the terms of the targeted intervention, the nature of the intervention, the support, but also the metrics that will get us out of targeted intervention. And our intention will be to for us to address those issues and to de-escalate promptly, as promptly as we possibly can. I'm told that we won't necessarily have to wait for the next tripartite meeting in 6 months' time, whether improvements made. When we get those metrics for de-escalation, if we hit those before the next tripartite, there'll be an opportunity for us to de-escalate before then. So that's our intention.
On a different matter, which is about primary care, the report mentions the GP in Carmarthen and Cymru. And I was just wondering, you know, this assurance around our systems of control and risk register, you think that we have oversight of anything that can happen in primary care if an incident like that repeats itself?
We do. I mean, one of the challenges there is that's a combination of things in terms of local authority and access and changing roads. At the same time as our fabric and infrastructure and what capital resource we have around rebuilding. So I think we understand the anxiety that the uncertainty around that has caused, but I'm confident that we've got a way forward with that, and that we'll take that learning forward with this as well, but how that happens.
Thank you, Nuria. Darren.
To make a supportive comment, we've got a published estate strategy which features largely our main building and hospital sites. We made a commitment for the next 12 months to do a similar exercise through primary community facilities. We operated over 204 buildings, some we own, some we don't, some we have lease relationships with. We're going to bring that to life over the next 12 months to help provide assurance and then risk stratification and some prioritization of work within that. So that's what we have commenced and we'll continue to do that.
No, and that's on the water agenda. Thank you for reminding us, Darren. I think that's an important point. Okay, any other questions for Richard or no? I think we will therefore move on to the quality, safety and performance section. Item 2.1 to receive POC reports from the Quality and Safety Committee. So Steve.
Thank you. So 2 meetings to report on, and the reports are in the paper. So I'll draw out a couple of pertinent points. At the 28th of November meeting, we had our first introduction to the continuous flow concept, and we looked at the SOP for that and the explanation that it was part of a system-wide approach to improve the flow of people through the hospitals, in particular Morriston. We've in subsequent meetings we've been asking executives how that is going, and of course it started well, but there have been some hiccups along the way which colleagues may want to comment upon. At that meeting we had a highlight report from the Mental Health and Learning Disability group. They've made very good progress in their new quality and safety structures. Generally speaking, mental health and learning disability are pretty strong on quality and safety. We don't have huge issues with them. There are a couple of coroner's cases which have made the news over recent months, which we at that service and we as a quality group keep an eye on. The performance report, Richard just spoke about it, and we're going to discuss about it in more detail later on. And the performance report comes to committees twice. It comes to the Performance and Finance Committee in terms of literal performance, and it comes to Quality and Safety Committee in terms of the quality and safety issues relating to performance. What we saw in that meeting was that there are areas which remain challenging, but also some good news. The 4-hour access of patients in the emergency department is in line with the proposed trajectory to 2 ministers. Endoscopy weights were down at that point. I think they've probably gone up a little bit since then. And we discussed the issues related to cancer. And as you'll be aware, colleagues will be aware, cancer is a complex issue because there are some cancer sites which do pretty well and others which are challenging. But executives were able to tell us at that point that there was positive news expected in performance in the new year, which we are now clearly in. And we had 2 external inspections to discuss at that point. 2 unannounced visits by HIW, which have now become quite well known. The first was maternity, and we're talking about that on the agenda today. Another one was the mental health facility at Caswell Clinic, where no immediate actions were required. So that was good news. So that was the November meeting. On the 19th of December, we had our second meeting in this cycle. And the focus there was on Singleton Hospital, and again on maternity, because that's where the main maternity activity takes place. We were informed of the workforce transformation that has been going on in maternity. There's been a great deal of recruitment. It was always planned that we should be recruiting in the in the autumn when midwife recruits became available. You know, in light of the HIW report and other publicity, it's important to note that we have recruited significantly, which is good news to our committee. But we have high levels of sickness and maternity, and at the time of that report being written, we had about 19% of staff were on sick leave and 9% on maternity. Sickness is not predictable. Maternity is somewhat predictable, and so it's good to note that the service is now over recruiting, so that we'll always have more than on paper we need in terms of midwives to carry out a safe service. It was noted the clinically optimized situation is that Singleton was at that point still high. And IPC, infection prevention and control, which system-wide is an issue for us. It's pretty well covered in Singleton. Morriston is the main area where we had concerns there. It's an old facility, difficult to clean and etc. And we remain an outlier in Wales in terms of some of the infectious diseases that are prevalent in the hospital sites. Just one highlight from the recent meeting, which took place last week, where there are no notes for this board as yet. We had a patient story from an oral health coordinator that community primary care and community have put into a number of our sites. It's one person, but she goes around the hospital sites on a sort of rotation basis, making sure that people have good oral health. It is a significant issue, especially with elderly and frail people that can't look after their own teeth. They can't brush their teeth, they can't clean their dentures, etc. And that leads to quite unpleasant circumstances, especially we were told when they receive visitors. Visitors like to kiss their loved ones, and it's difficult to do so when oral health is poor. And so what this lady and her team does is resolve that issue, basically going around helping people clean their teeth, keep their teeth clean, keep their dentures clean, and making that aspect of their stay with us that much more positive. So that was a good patient story we had at the last meeting. I will stop there and happy to take any comments or questions on what I said.
Thank you, Steve. Nuria?
It's not a question for you, Steve. You'll be happy to know, but more about understanding the practice of patients waiting on wards before a bed is available. And it's just to do with wanting to check about the impact on our performance figures in particular in relation to before the 8 and the 12-hour wait, as to when, you know, if a person is waiting on a ward without a bed, is their clock still ticking? The reason why I'm asking is because we know that sometimes that can incentivize the wrong behaviours, and it's happened elsewhere in other areas across the country. So if there was a risk, I just wanted to be alerted that the risk exists.
Thank you, Nuria. Deb?
I'm happy to take that, Chair. So we don't have patients waiting on a ward without a bed. So we put an extra bed on the ward, which isn't ideal, but we create an extra space to put the additional patients on. So they're in a bed. It's not the best environment. We want to improve that. And they're pushed to a ward predicated on a discharge coming up within the next few hours. So it's a short space of time that we've got the extra patient on the ward. Sometimes that's not what we would want, and we acknowledge that, but that's how the flow situation should work. With regards to our ED clocks, as we call them, for us, the clock starts when the patient comes in an ambulance, the clock starts the minute the ambulance turns up outside. That whole time is captured. Once they are moved out of the emergency department to a ward, then the clock does stop, and that's in line with national guidance.
Thank you. Thank you. Any other questions on the Quality and Safety Committee? I know there were questions around continuous flow. Do we want to say that for performance? Or, yeah, bring that in, or was it you, Nuria, that wanted to raise that?
There's always a question about continuous flows. And do you want to come in?
Probably an extension of what we've already been discussing.
Exactly, that's what I was thinking. It's probably part of how all of that works. So how does our system, helps transfer the patients as fast as possible to, and how does that link in with our performance in terms of continuous flow, and how does the system work in terms of overflow and allowing capacity to
Yeah.
through the
What
system?
does it mean in practice, I think is what we're asking.
Yes, how does it look like?
Yeah, so when it works well, so we've poached the model from North Bristol where it has been implemented successfully there. After a lot of hiccups, so it's a continuous cycle of implementation and focus to make it work properly. But how it should work is it's based on expected discharges from a ward. So if we know historically, based on our data flows, a ward will discharge 2 patients every day, then at periods during the day, we will send a patient in advance to make sure that bed is used as soon as possible once the patient is ready to go. So it'd be 11 o'clock in the morning, we'd send the first patient, or perhaps 1 o'clock in the afternoon, we'd send the second patient to make sure those discharges happen. When we implemented it initially, it was really successful. So we had really good buy-in from the front door department, so emergency department and AMU, and not a lot of pushback from the ward area. So they were quite accepting of the model. Unfortunately, over the winter period in particular, the discharge rate has slowed. So where we are predicating on 2 or 3 discharges a day, those discharges have been slower to come online, which has meant the flow hasn't been continuous, which goes against what we're trying to do on that. So we're not giving up on it. It's still what we want to do as an organisation to make sure we are preempting and moving the patients as quickly through the system as possible. And interestingly, during the period of industrial action where we had more consultants in the system, one of the feedbacks from our neurology consultants was the beds don't come available quickly enough. So we know patients go in, but it's not available for us to admit into. So we know there's more we can do in that space area, and that's where we want to go with it. So we're going to revisit it and reinvigorate the project and get the team wrapped around it. As part of the targeted intervention, we come up with a whole plan of how we're going to manage that, and that still remains a focus of how we get the flow out of the emergency departments and front doors and into the wards.
So presumably we'll get an update. At some
Yeah,
point.
yeah, we can give as many
That's-
updates as needed.
Yeah, no, good, okay, thank you. And Louise?
One of the things that exercises our minds in the Quality and Safety Committee is the clinically optimized patients. And I think we have kind of mindset that that is affecting the continuous flow. And I wondered if you could comment on that, because I have a feeling we're the end of the tunnel.
Yeah, absolutely it does. So we do have too many patients in particularly the acute hospital beds who don't need those acute hospital beds. So I won't say they're inappropriate, but they don't need the bed that they're in at that point in time. They should either be within the community model, the rehab model, or out in the community services, accessing the care there. That's going to be the main focus of where we're going next. Is the measures focus on the front door because that's the natural and easiest thing for us to measure. But it's not an emergency department problem as such. Not that there's not work to do there, but it's a system problem. It's the flow out that we need to focus on to make sure we get the patients out and we can move patients through to the wards. So as part of that work, so Angela's hugely supported me in that area. We're developing a frailty strategy that will be focused across the boundaries of the health board. So not focused on Morriston, but bringing in primary community services to support. As a health board, we've invested a significant amount of resource out into the community services, and they're not dovetailing as we need them to at the moment to make sure we can take the patients out, give them the assessment at home that they need so that we can gauge what care they need in the community, and either bridge that with the services we've got available or tap into the domiciliary market to make sure the patients get what they need. So that's going to be a huge part of what we're trying to do going forward.
And what's the kind of timeline for that?
So the development of the strategy is now. So we've got meetings going on later on this afternoon that we've got to attend Morriston for. We've appointed, so Liz Davis is one of our geriatrician consultants. She's going to lead on that work with Angela. So it's going to be at pace over the next couple of months.
Thank you, thanks Anne-Louise. And clearly the board will be very interested in seeing that. Richard?
Just to address your point as well, I think continuous flow is a bit of a catalyst for the discharge side of things as well as being something that actually encourages discharge. So rather than it being the other way around, continuous flow is there to help us on that process. And then just adding one thing to what Deb has said, the other element I think in terms of patient benefit is that the patients go to the right ward the first time, because there previously were a lot of instances where patients would be going to any available bed, but not necessarily in the right ward. So this gets them to the right place more often.
Thank you, thanks very much. Any other questions? Yes, Gareth?
And just to confirm, all areas on wards where we put in extra patients are risk assessed
Yeah.
So each area has got its own plan, its own process that we will only transfer there if the assessment is appropriate, and our clinical site team and matrons undertake that.
Andrula. So, that's some hands. So I've got Andrula, then I've got Steve, and then I've got Jean.
Just on the point of the clinically optimized, I think there's two elements. One is understanding what the patient needs, so having all of the assessments in place to be able to do that. And then the second bit is having the services in the community ready and their specification need to match what those needs are, because otherwise you will have those bottlenecks at every point. So it's a little bit of inward reflection on, are we having a real understanding of the needs of the patient? And that needs to be assessed in the right place, of course, because a lot of the hospital assessments might not be so accurate, and much more accurate if you do them in their own home environment. So we need to be able to make sure that we're assessing them correctly in the right place, and that having the services who can then capture those needs in the community. So that's the piece of work we're trying to do, to try to really, as Deb said, dovetail those two aspects together, because sometimes there are gaps, and that does mean that services need to change their specification to be able to accommodate the needs of patients.
That sounds quite staff intensive to do that.
And I think it may be an additionality, but it may also be repurposing some of the staff we've got, and really using them wrapped around the patient's needs.
Thank you. Thanks, Andrula. Steve?
It was just to come back to Gareth's point. When risk assessing whether a patient could go into a particular bed or a particular space in a ward, is there evidence of that risk assessment? Is it written down and auditable?
It's documented, but remember that the risk assessment as well looks at the whole pathway. So if WAST is saying they have no ambulances to go to 999 calls, if we have an A&E department that we need from there, number of ambulances outside, that then assesses as part of the risk assessment where we place patients. So it is
That's actually really important, that wider system risk. Jean?
Yeah, may I ask for some sort of explanation around the issue that's highlighted underneath Port Talbot Singleton highlight report, which is the out-of-date timeframes. Although the narrative relates to the nursing staff transferred as part of the change, and the operational team were now looking at historical incidents, does that out-of-date timeframe refer to that particular statement, or is it referring to something else?
Yes, please. Thank you.
It's in the papers.
Yeah, at that point in time, the service group had produced their report earlier and submitted it. And then there was a report later on the agenda on risks that referred to risks which had been produced later. So it was around the timing of the two reports really. So the Singleton service group report was produced earlier, so it didn't have all the updated information that was in this report later on the agenda, and that was picked up as part of the annual challenge.
Thank you. Thank you. Will you read the papers in great detail? Okay, any other questions on Quality and Safety Committee? No, let's move then to Rena with Performance and Finance Committee.
Yes, thanks, Chair. We've got reports of two committees and a member on the same committees. If I look at the November one first, we've got obviously within the finance, we've been focusing our questions and our assurance on how well are we doing in terms of reaching our deficit control total of 17 million by the end of March. A lot of discussion really about this, in particular in terms of variable pay and prescribing costs, which have increased. So we were seeking assurance on those two aspects, particularly given the amount of recruitment we've done on international nurses. Then in terms of the performance on the November one, we talked about clinically optimized, where it's clearly focus of a lot of concerns at the moment. The thing about neck of femur and broken hips was quite an interesting debate. And obviously one of the key things there is to have ring-fence beds available for these patients who are coming through absolutely on a regular basis. And I found it an interesting statistic that we have the highest number of hip fractures in Wales as a health board. So obviously we need to ensure that we've got the right pathway for these patients to be seen quickly and to be operated on. Planned care was looked at in detail in November, and we've already been discussing the orthopaedic situation, which is obviously improving with the new theatres in the Target. We had a particular look at speech and language therapy, which is one of our smaller services, but one of the concerns there is these new responsibilities for additional learning needs, which have been transferred onto the health board with no additional resources. So one of the things we have agreed is that we're doing a deep dive on this area in next month's committee. I move on then to December's. Again, obviously the finances is one of the focuses there, and we have been again looking at those, but there was some improvement in terms of the variable pay position, which was useful to that. We had a deep dive into urgent and emergency care and the continuous flow, which we've been talking about. And in particular, what arrangements were in place to assist with the push out as opposed to the push in terms of the emergency department. And it was useful to know that we had surge beds available in Gorsinen and in Bonamine House and also in Singleton. Just to comment on this week's Performance and Finance Committee, we had a particular deep dive into prescribing, which was very useful because this is a large area and large costs involved. But it was of interest to the members, the extent of work that is being done in prescribing. And in a sense, if we weren't doing that work, how much more costs we would have to bear. And it's really important that we keep a close eye on this. And the other deep dive report we received this time was on immunisation rates in Swansea Bay, which Keith presented to the committee, and I think is particularly pertinent given the situation with measles at the moment. Thanks. Happy to take any questions.
Thank you very much, Rena. Questions for Rena? Yes,
A comment really. There is a very robust plan in place for the delivery of the 17 million from finance. We have regular updates on that. There is obviously still risks involved in that, but again, the transparency of those and the debate of those is strong, isn't it? From Sam and Darren. So it's just to highlight there are risks as we move forward. We've hit 17 million, but it's that debate is there, and it is very robust.
Yes, yes, and there is a plan for the board to be appraised of where we are in good order on that, but it is no. Darren?
Just briefly, the detail goes to PFC. We don't bring the landing plans. We go in detail to the board. I intended just to highlight some of the positive and negative movements in that plan.
I think that would be really helpful. Thank you, Darren. Yes.
And Julia?
Just on the point around the neck of femur
Yes.
patients and the absolute recognition that ring fence beds are going to make a difference. And there is a lot of work being happening at the moment to map that pathway and how that would look like. Clearly, there are more variables to it, like making sure that we've got a consistent length of stay, otherwise the whole thing will fall again. And as well that we've got the right workforce in place with the appointment of a number of orthogeriatricians. We now feel confident that we've got the right workforce to be looking after these patients to ensure their length of stay is managed appropriately. And the aim would be then to look at ring fencing beds for that patient ward.
Right. Thank you, Rena. Any other thoughts, observations? Chris, sorry, I didn't see you.
Thank you, Chair. I think it is also a comment on the fracture neck of femur. Our rates are high, but I think there's also a lot of work we are doing and we need to do in the falls prevention area. And so I think that's an important focus for us. Angela, myself have been looking at reviewing what we're doing in this area, looking at strength and balance and that and what's being provided in the community.
Great.
So I think we need to get upstream.
Yeah, great, thanks.
Absolutely back up what Chris has said, and also in bone health.
Yes.
So when people are doing for, they're less likely to break.
Yeah. Deb?
Just to add to that, Chair, so I'm now chair of the Committee on Older People's Programme Board for the Regional Partnership Board, and we've added 2 work streams into that, and one is falls prevention and intervention in the committee to make sure that what we're doing in health is absolutely being dovetailed across the RPB as well, and both local authorities have signed up to that.
Excellent. Good. I always like to hear the work we do in partnership, because that's fundamental, particularly in the community.
I think we shouldn't lose that point, Chair, in that that's a primary, sorry, I was going to use the word primary, I don't remember. That's an excellent example of where primary to secondary care has a highlighted pathway. So I think we shouldn't lose the work that the teams are doing on that, because that integration of pushing the service nearer to the patient, that's a wonderful example.
Good, okay. Thank you very much indeed. We will now move on to the, yes, we're now on to the HIW maternity report. Thank you very much.
So members will be aware that Healthcare Inspectorate Wales carried out an announced inspections in the maternity services, following which 7 areas required immediate improvement actions, followed by an overall improvement action. Healthcare Inspectorate Wales have confirmed that they accepted the plans and took assurance from those plans, and they will publish together with Healthcare Inspectorate Wales inspection report on 15th December, and that was shared with board members at that time. This report just then summarises where we are against those improvement plans, sets out actions taken and the actions to be taken in accordance with the timescales set. The service groups have really engaged with this and already have implemented 51% of the actions and making really good progress in our area. I think that's all I wanted to say, Chair, and happy to take questions other than to ask the board to consider asking the Quality and Safety Committee to oversee implementation of the improvement plan. We are due to provide an update to Healthcare Inspectorate Wales in March, and then the plan would be reviewed by the committee then in February. That was accepted by the committee.
Thank you very much, Hazel. Is there anything you wanted to say? Gareth?
Being a chair, so if we just more pick up just where we are in terms of the improvement work within maternity that makes in the HIW position.
I think that would be really helpful. Thank you, Gareth.
So the service remains operationally very busy, and within that we really focus on how we support our staff and our families there. And we have a weekly meeting, an open forum with all our midwifery and neonatal staff. We've had as many as 80 staff in those meetings, where we talk through some of the challenges we've had, talk to the HIW, we do take feedback and support there. And the external review is on the agenda today, and that's being formalised and launched, and we'll go on to that in a second now. But we're working closely also with our Maternity Voices Partnership. This is a group of service users who feedback and experience of their care at Singleton and within maternity services generally. Now, to mention the HIW review, we've got a weekly meeting with the team working through the actions there, and good progress is being made. And from an establishment perspective, we are now fully established for midwives, and we have been for a wee while now, and we're over establishing now, and we've got a little bit of a challenge with maternity leave at the moment, just to be really sure we've got enough midwives to provide care and support there. The unregistered worker was healthcare support worker was mentioned there. When we went out for our maternity support workers previously, we appointed 15 and we had about 120 applicants. We just advertised for eight healthcare support workers, and again about 110 applicants. So there's a real willingness to come and work within the service. We've been working closely with Welsh Government, as Richard mentioned earlier. We've been put into enhanced monitoring for maternity services. We've got our first meeting on the 20th of February, and we're working through the terms of reference with our clinicians now. Just to be sure we're focusing on the right things and this overriding focus in ensuring our services are safe. We also had obviously a lot of interest in our service, and got a rolling programme of politician visits, and that is great because it gives the opportunity for them to ask questions of our staff, of our families, and be completely transparent in what we do there. The birthing centres in the throes of being reopened. We've got a gateway process in place for that. And there's a major focus on this, obviously, and that's all being worked through the internal governance process and the development of a maternity improvement board, which our medical director is going to be chairing.
Thank you. That's a really helpful overview, Gareth. I can see lots of hands. I don't know which order they went. And thank you. So Nuria first, then Nick, then
Good, Ashley. Okay, I'm just I'm doing the audity bit here, which is about the Health Quality Inspection Wales Improvement Plan. And it says on the report 51 of the total actions have been already completed. There is 2 actions that were due to be completed in December, and I just wanted to check that those have been completed.
They would have been, yeah. What we've got is an up-to-date position there, going through the detail of all the plans. And that's a real challenge for us, and I think it's important for board to be aware of this. It isn't just a HAW plan. We've got our Rockington plan, we've got our self-assessment against that. We've got quite a bit of work on going around enhanced monitoring the like there. So bringing all that together is a key focus for us moving forward.
So in terms of the January recommendations that's there in hand, what you're saying is that it links in with all of the other plans that you've got in place at the moment. It's just the issue around mandatory training, etc. I know it's quite complex and one that keeps coming up when it comes to reviews. So it's one that I know takes time. So it's the realism, so that if we are going to hold you to account, we can hold you to account for the right reasons and in the right time frame.
It is, isn't it? And we've had a number of discussions at board around mandatory and statutory training over a while in terms of not just outside maternity. Now, the HIW review has obviously given us a major focus on that. When your staffing is challenged, it's invariably the first thing that gets compromised. So the fact that we're up to establishment now, the fact that we've got this major focus, the fact that we released in from a safeguarding perspective, members of the central team to go and support there, from an IPC perspective, members of the IPC team will really get some momentum behind this. You know, and we'll be looking to get to it at least 85 to 90% within the next 3 or 4 months. And of course, the quality and safety are going to oversee the improvement plan. We can bring this update every month there in terms of assurance and accountability.
Thank you, Gareth. I just couldn't let it go because it's another report in front of us.
Yeah, it's important. It's really important. And I'm going to, I think there are some specific areas that we'll want, if the board agrees for the Quality and Safety Committee to oversee it, we'll add those in as specific areas. Debbie, do you want to just come back on that?
Yeah, well, I wanted to make some general comments about workforce, if that's okay.
Yeah, that'd be really good. Thank you.
So in terms of the standard mandatory training, we are working through that. And as you know, we've got our action plan, and that is being monitored by the triumvirates and the senior management team. What they've actually done is they've focused some midwives to focus specifically on CPD. So we've now got 2 additional registered nurses who are working with the team around CPD. Which is really excellent. The other thing I wanted to say is that we're focusing on our health and well-being. There again, that's being monitored in the group that Gareth is talking about. We've got the psychological support that is ongoing, and the health and well-being and the counselling support that we're providing for staff. The other thing I want to say is that we are making some excellent progress with our recruitment, and as Gareth said, the obstetrics department is fully staffed. We've got, I think, about 7 full-time equivalents just going through the recruitment process as well, the onboarding process. With that, we've been able to reduce our risk rating from 25 to 20. It's still quite high, but at least we've been able to do that. And then the absence. I know the absence has been of concern, and Steve mentioned that earlier on in the meeting. We are seeing a reduction. Again, it's still high, but we have, you know, it's recognizing the fact that the department has gone through some significant changes, which has resulted in the absence, as well as the maternity leave. But that absence now, I think, Steve, when you met with the team, they said about 12%, is now gone down to 9%. So just to give the board some assurance around the progress that we are monitoring in the groups that Gareth was talking about.
Thank you. Thanks very much, Debbie. Nicola.
Yeah, I just wanted to talk a little bit about our IM visit before Christmas. It was a fantastic opportunity to sort of have those raw conversations face to face with staff. But I think what was quite evident, every staff member is so dedicated and committed that I think that really needs to be fed back to staff. My first question, actually, I think you just answered really about strategies for long-term staffing. But just wanted to ask really, what are we doing to sort of check in on the well-being of our current staff at the moment? Because I think, especially with the extra eye over the department, I think it's key that we are sort of keep a little eye on our staff.
It's been a really challenging time, isn't it? You know, and in terms of not just for our staff, but for our families as well. In terms of those who use our service, Now, we've got a really good and robust oversight process for our staff. While I meet with the staff and Richard and Hazel on a weekly basis, they also have their internal staff meetings. We've also commissioned our psychology teams to walk the floor, and our HR business partners are walking the floor as well. And also we've got our guardian service should anybody have any concerns there. And just getting to a point whereby, you know, the openness that we worked really hard to achieve is maintained there, you know, and I think those of you as who know our midwives and our maternity service, they're quite forthright and quite straightforward in what they want to do, which is ultimately provide the best care possible. We continue to monitor that now via the improvement group in terms of any feedback there. We've also got those informal mechanisms. All midwives have supervision, and the relationship we got with the midwifery supervisors. If issues or concerns are raised with consent, they're escalated to me directly. So again, how we pick up there. There's also, you know, it isn't just midwives. And I think it's important to make that point there. You know, we've got some really dedicated medical teams within our neonate service and within our obstetric team, and really bringing them into the system and the process we got is where we've got to get to. I wouldn't say it's 100% there yet. In terms of their role, our doctors tend to have support in different ways, and that's fine. Just make sure that we're aware of everything, you know, and that we've got a way of taking it forward there. And again, the visits are so important because, you know, I hope, you know, when we visited, we let you go and didn't stand by your side, and you know, it got to get feedback, you know, honesty and integrity of our midwives.
Thank you. Are you coming back on that, Alan? I'm coming back on that. Yeah, okay, and then I'll go. Are you on this as well, Raj?
Yeah, on something else.
Oh, something else, fine, okay, I've got you then. Yeah.
It further to the visit, in the neonatal unit, a young doctor, young consultant talked to us, and her spirit and enthusiasm for working in Swansea Bay, the team spirit she describes, the cooperation and collaboration between all the members of staff really shone out, and it was really heartwarming. The other thing is we spoke to a very young mum on board, and she was so enthusiastic and grateful to the staff and the care that they'd been offering to her. Sadly, one died, but her twins. And she commented on the pastoral support that she was given, rather than just the medical support to the babies, but the care that she herself had received while the children had been on the ward. And also we talked to a couple of nurses who'd obviously been there for years and years and years. So in terms of retention, it looks as though retention isn't a major problem in that unit. But it was heartwarming.
Thank you. Thank you very much. It's important this gets fed back and please feed back to the service as well. Yeah. Okay, I've now got Jean, then Raj, then Yuria.
It was an observation, Chair, that we've had a huge internal focus, laser focus, in fact, on maternity for many months now, both the executive and board. But I think we shouldn't lose the enormity of the work that the independent review and the HIW review have brought on that department. I think we need to remember exactly what managing those two disparate reports look like for the staff, because I think that, and for us as a board, to make sure we understand the difference between those two.
I think that's such an important point. The flip side is the HIW identified a number of areas that we needed more, you know, so not doing it isn't an option. But I think you're right, Gina. I think the degree of input that many around this table have had over a number of months and years now, it feels like, has been enormous. We've got to get it right. And I'm not saying for 1 minute that it isn't, but we've got to get it right in terms of the HIW findings and getting to a point whereby, you know, families within Swansea Bay, Heathcote, Talbot get the best care they can, and we can provide. So it's important to note, but we still got work to do, I think, is my reflection.
I think that's right. I think that's absolutely right. So I've now got Raj.
Thank you, Chair. And I think the fact is just echoing the what Gareth and Louise actually said. It's actually the passion of the clinical team in delivering this service is actually extremely palpable. So that the fact that even before these reports came in, it needs to be noted that the fact that the clinical teams were already on the case with regards to it. So when the questions were actually asked, there was actually no particular surprises that was actually coming from the team. And that passion has actually been quite evident when we actually meet up with these clinical teams, and that's actually there and to be noted. Irrespective of the HIW report and on the enhanced monitoring, what we will be also be doing is actually looking at the compliance with regards to MAT NEO, and to see where the hotspots are, where the issues are, and to see how compliance is actually being maintained. So with regards to safeguarding, or if it is actually with regards to the IPNC stuff. So that will actually be focused on as part of that, saying that what the local service group will actually be doing to deliver, and there will be an oversight.
Great, and that will feed up to Quality and Safety Committee. Good, thank you. Thank you, that's an important point, Raj. Jean? I asked my question. Sorry, yeah, no, I can see that too. Nuria?
I just wanted to reiterate the passion for what you've just said, Raj. I was going to talk about compliance and we're going to talk about passion because I think they go hand in hand, and that actually did come across in the visit that we went to. One of the big asks for staff, which I thought was important that we brought to board, was that we support them in sharing that passion for the service with our communities. And I thought it was a really good opportunity for us to do that in one of the next items on our agenda, which is about engagement, diversity, inclusion, belonging, and our long-term vision of how we communicate what's going on with our services to the broader community. So I just wanted to make that point because I thought we did promise that we would take it to board, that we would share their passion for the service, which is very eminent.
Thank you, Nuria. Pat?
It's great to see the progress with recruitment in maternity. I was just going to ask about the birth centre and the home births. I mean, obviously they've been closed now for 2.5 years with a big impact on parental choice. So it would be good to understand or to see soon what the timeline for reopening those are. And just to raise Keith's question that he raised yesterday in our meet, will you be looking? Will the birth unit reopen in Neath Talbot, or are you looking at possible co-location in Singleton? So reducing any clinical risk to patients. Is that under debate?
Yeah, it was a long time ago now, doesn't it? In terms of when we initially closed it, and just to remind the board, we closed it for safety. We were in a position whereby we weren't able to staff the birthing centre appropriately, and made the really hard decision to close at the time there. The flip side of that, as you say, it's medicalised maternity care by the very fact it's all on an acute site there. So the plan moving forward, and if you think of where we've got to now, the reason why we closed it was safety. So all our community staff have been supporting Singleton Hospital. They've been working in and out of there, and much to their disdain really, because if you're a community practitioner, you want to work in the community. By getting to full establishment, that's enabling us to release those staff back into the community, and by rejigging the establishments, for my technical phrase, rejigging the establishments and getting Band 7 midwives in there, and developing the team to get further, that enables them then to own the Neath Talbot Birthing Centre and work out to there in terms of mums having their babies there. Now, it's a really important point there. The choice thing is imperative. We have to give choice, but that's also got to be based on clinical condition and the fact that if a mum needs consultant-led care, they won't be birthing in the Neath Talbot Birthing Centre. They'll be birthing in Singleton. Now we know that things don't always go well. That it's a really complicated business, isn't it? Giving it's the man saying this. It is. So we need to be in a position whereby if and when complications occur, we've got the opportunity immediately to transfer people back. Now, part of the gateway process isn't just about staffing. It's about pathways. It's about liaison with organisations like VAST and being sure that it's there, and the environment of care and all those things that enable us to provide safe service. If any one of those isn't in place, then we won't be opening. And I think it's important board realise that as well now. And our plan is to open at the end of March, and to get our teams working from that period. if through the gateway approval process in February, March, we say, well, do you know what, we haven't got that assurance yet. We got flexibility to knock it back 2 weeks, 3 weeks, 5 weeks, whatever we need to do there. But the safety bit's imperative, and the repatriation component within that. Part of the gateway is checking the frequency of repatriation to Singleton and how we managed that previously. We didn't have really major concerns previously, and being sure that that process is as safe as it can be moving forward. But again, the gateway process, there's no reason why, you know, for quality and safety, as part of the HIW overview, to get updates for where we are with that as well. So that's an quality and experience as well, would be my reflection.
You read my mind. I think it would be quite helpful for quality and safety to see that, because I think it seems to me, while we've had such a long period of it being closed, we absolutely want to be very sure about all those aspects that you've talked about around the safety, but people also need some clarity, and it would not be ideal to keep slipping it.
Yeah.
So it's that balance between giving the clarity and being sure about what we're doing. And I think it would be helpful if quality and safety can oversee that.
And what we don't want to do as well is open it.
No, close it. Exactly right. Exactly
It's
right.
got to be consistent, you know, because
Yeah.
the choice thing is really important.
Yeah.
It is, you know, and we recognise that.
And when I went, I remember talking to the midwives about this, and the other point they made was that there is an obstetric-led unit has fewer interventions. If you give birth and you shouldn't need interventions. If you're in an obstetric-led unit, you will tend to have more interventions than in a midwife-led unit. So there are good clinical reasons. They were very clear about that. So I think all of that needs to play in. But yeah.
Just one point on top of that, Chair, if it's okay, we are actually recruiting for a director of midwifery as well. And this will be an exceptionally senior post. I'll have a direct line of accountability to myself and the service delivery group to lead this for us. And it's a wee bit of a gap for us at the moment. We've got great staff working operationally, but we need that strategically to oversee this. And the adverts will be going out this week for that.
Okay, so the advert's out this week, so we would hope to have someone in place quite shortly.
Yeah.
Good. Are you coming back on this?
I am, yes. It is to do with co-location, and I think because Gloucester's in the news because 2 babies died as a result of the midwifery unit being separate from the main hospital. And with other IMs, I did an interesting walk around the minor injuries unit at Neathport Talbot, and what we were told was the success of that minor injuries unit has meant that people with major injuries are being deposited on their doorsteps, and all they can do is stabilise and call 999. And of course, the problem is now different, I think, from prior to COVID and the closing of the birthing unit, is that the ambulance wait times are so much greater, and they have to wait sometimes a huge long time with the serious injuries before they can be transferred to Morriston. What happens when that happens in the birthing centre? Because the situation with the ambulances is not what it was when the birthing centre closed. And there's that concern.
So are you coming back on?
Yeah, and coming on
this?
that point.
Yeah, I'll let you come in first. So have your thoughts, Gary.
We recognise the risk that we've got with some services in Neath because of the position that we've got with ambulance demand and obviously the huge demands in the community. And they are a community response service, which is why sometimes the delays at the hospital front door are longer. What we're doing as a health board to try and mitigate all of that is commission an additional service through Welsh Ambulance that has a designated transfer vehicle available for us up until 2 o'clock in the morning. Okay, at the moment there is a designated service for adult critical care that we've got in place between 8 AM and 8 PM. That it's an all Wales service, but it's used predominantly by West Wales because other health boards have their own designated service, but it stops at 8 PM. So we're looking to extend that period just to give us belts and braces that if we do have urgent transfers to Morriston or to Singleton, or from Singleton to Morriston as well, that we've got the vehicle that we can use. So we're hoping that be in place partially very soon and then fully as we go into next financial year. It's the delay isn't with us. We've been trying to commission this now for probably 12 months, and there's been a delay in getting it over the line. But that's the intent, just to make sure that we've got more assurance in the system than just the 999 call. But that said, the 999 call, whilst does triage on clinical need, not geography. So if it is a dire need of patient to transfer in, that will be prioritised in line with community as well, but we all know the demand for WAST is high.
Thanks, that does give some assurance. And I suspect it's also, I think it's reassuring that the some really senior midwives coming in perhaps can reinforce the importance of it is the woman's choice, but it has to be a properly advised choice, a safe, informed choice.
Yeah, thanks, Anne-Louise. Gareth, do you want to come back?
I think Deb.
No.
That's
Fine.
fine.
Great, excellent, thank you. Rena?
Yeah, it sort of links in a way, but I just wanted to ask Gareth for more assurance in the context of that we are workforce planning in terms of our maternity going forward. Because clearly we got into a sort of crisis mode in terms of the lack of staff. And I want to, I suppose, seek a view as to how we can ensure that we don't get into that situation again, and how far are we over recruiting? Are we taking into account maternity leave? Because obviously the type of people, in the sense, a lot of the staff that I witnessed there were quite young midwives who possibly are going to go on maternity leave. So how are we anticipating our staffing needs going forward to ensure that we don't get ourselves into the same situation that we were in?
Yeah, that's a really good question, isn't it? And just to confirm, we've had an active recruitment process throughout forever in terms of the service that we have there. We know there's a national shortage of midwives, and we are not unique in our challenge, I think it's fair to say. There is only one intake of student midwives a year, and I wouldn't want board to think that in some way we've been sort of not had our eyes on this, and suddenly we've had HIW in, and now we're recruiting. Our challenge in terms of recruiting all the time, we've always got open adverts in terms of getting midwives in place. That's been there probably for the last 10 years or so. The real challenge that we have is that we have one outtake a year of student midwives. That's come into work in sort of October time. That has enabled us now to really keep our numbers high and become fully established there. The key bit around this, would be my reflection, is retaining them. And being really clear that we're not having this leak of midwives out of our service there. So why is Swansea the best place to work? You know, what is it that we can do for you in terms of your professional career? How can we support you through things like maternity leave and the like there, which are really important? So there is a retention and well-being plan within the service delivery group. They're working with our workforce colleagues to really get on top of that. And we've undertaken a workforce redesign project as well, in terms of being sure that we can have registered staff and unregistered staff, and seeing how they all fit together there. Now, operationally, the process, and if you could just bear with me for a second. Every day there's a daily staffing meeting. This takes place at 9 o'clock every morning, where the previous 24 hours are reviewed and the subsequent 24 hours are planned there. Now, that brings up any risk, any harm, any incidents, and how we're going to deal with that moving forward. We were also, for the most part of the year, prior to HIW, been achieving the numbers that we've advocated in terms of what we need for each shift. That would be 14 midwives, and now consistently we get in 14 to 16 midwives on shift there. Continuous recruitment is in place, as I mentioned there, and the output of midwives is there as well. Now, the key bit there is working with HIW as well in the medium term, to be sure that we have a number and the right number of midwives coming through, and we can have 2 outputs a year in terms of midwives joining us. We've got to be over this like a rash, Rena. I think, you know, we can't be in a position whereby we have surprises. So again, as part of the internal work the team are doing, the staffing component, again, is part of their internal governance. They checks their balances, and again, that will feed into the HIW plan, because again, they mentioned and noted this as being a real challenge for the service. I don't know if I can give you 100% assurance, and it'd be wrong of me to say so, you know, but what I can say is we work consistently to get to the point whereby we'll maintain the numbers that we got there. Because, as I say, maternity staffing is a wee bit of a challenge everywhere, but we'll maintain that focus.
Yeah, no, thank you. It raises a really important question, Rena. Does that give you assurance?
As far as we can, as you say, you can't give 100%.
No, okay. And it will be reviewed. So I'm not seeing any other hands. Are there any other questions? No, so I'm going to ask the board, are we happy to delegate this to quality and safety to oversee the action plan? Critical meeting in February, but thereafter as well, because there are actions that go beyond that. And I think there were some specific things that we wanted it to look at in particular, which I wrote down now. Yes, statutory mandatory training, compliance particularly, and the completion of actions, the compliance, Nuria's point about the compliance, and in that, a scrutiny of whether we are, whether the actions, you know, some of the ones going forward appear quite complex. So how do we break those down to get some milestones and some deliveries along the way? So I think that's fine. Steve, if you are content to do that.
I am content.
Fine.
Yes, colleagues.
Tom.
Just a comment. I know this is, I was going to pick this up in the reflections on the Workforce No D committee, but I just wonder whether there's anything we'd like to refer back to Workforce No D to pick up specific on that. I know we've had a big focus on stat and man training and more broadly things like PADR for a long time, even back when you were chair as well. But I wonder whether there's anything we want to specifically pick up from a
I think
workforce.
I'm seeing nods, and I'd certainly support that. So I'll let Debbie come in and then Nuria.
Tom must have read my mind. I was just
Yeah.
going to say that we actually do have a recruitment and retention plan for maternity,
Yeah.
and we can monitor that via Workforce No D.
Excellent. That sounds great.
Absolutely, no, I agree with that. I think that the other point missing in that list, Emma, is the neonatal, the updates on the neonatal and what's happening with Singleton, etc. in terms of opening
Yes.
up.
Yes, yeah, well, we've, in a sense, I'd already passed that on, but yeah, you're absolutely right. So in summary, Quality and Safety Committee will oversee the HRW report with a particular view on the aspects of statutory mandatory training and the reopening of Neath Talbot. We will refer to Workforce and OD Committee, the workforce and retention plan specifically in maternity. And while we're referring, I'd like to, that statutory mandatory training focus that the committee does, I'd like to make sure that that looks at hotspots as well as the overall. I think that would be quite important. Excellent, thank you very much indeed. All right, so we now move to the next item on the agenda, which is our independent review. Are you going to lead on this? Yeah, thank you.
So the board announced in December an independent review into the Women Services. The review will focus on 3 areas covering patient development, engagement, which will include staff and service user voice, which is very important, leadership and governance. Margaret Bowram KC has been appointed as the oversight panel chair and is in the process of appointing panel members to assist her. There are draft terms of reference which are helpful drafted and provided the oversight panel chair with, and she will now review these and amend as necessary and take advice from the oversight panel as well once they're fully set up. I think those are the main issues, just to say that it's in progress and that we will keep the board regularly updated in terms of milestones and the oversight panel.
Thank you very much, Hazel. Any questions on this? No. Okay. So I think this is a really important review for us. Over the past few years, we have undertaken a number of reviews and had a number of reviews into our maternity services, internal and external, and they've all provided, as has been reflected in the previous discussion, favourable feedback on the culture, safety of our clinicians. So I want to be clear that as things stand, the information provided to this board does not suggest the service is fundamentally unsafe, and I want to be really clear about that. But there has been short staffing. We've had a long conversation about that, and that there have been serious concerns raised in the media, and that makes this review an important one to undertake, and one that I know this board is fully committed to doing. The independence of it is paramount because of the media interest and because of the fact that people don't trust that we are going to do this independently. And that is why I am wholly committed to having this totally independent. The other thing I would say is that regardless of what we think of the service today, I know that the service and I know that this board will embrace whatever findings this review comes out with and will address them in an expeditious way. And I reiterate that whatever this review finds, we will implement. In the meantime, I would like to reiterate what people have said about the people that are working in this service. I am concerned about the welfare of our midwives and our doctors that are working in this service. It's been very, very high pressure for them over the last few weeks, and they need to be given the space to implement the findings of the HIW review and to engage, as I know they will, with this independent review. I think that's all I really wanted to say, but I do think it's important that as we instigate this review, that we fully commit to it as a board, and that we reiterate the importance and our complete agreement and commitment to being fully independent through the oversight panel. Thank you. Good. Okay. We are now going to move on to the finance report.
Thank you, Chair. So the paper for the board today is the month-line financial position, which is at the end of December. I know colleagues will be familiar with the content, so I'm not going to turn the page. I'm just going to highlight a few questions. Bottom of page 2 shows the indicators for the month. So month 9, our revenue position underspent by £200,000, which is stabilised at overspend at 41.5 million. The board will be aware that we are committed to a controlled total of 10 million. I'll touch on that briefly. That's making the report. There's some updates which have happened since then. In terms of the key measures, capital is set again from page 2, and whilst we're reporting small predicted deficit at year end, we have mitigation in place to allow us to have confidence that we will meet the capital resource limit, as we have done for many years. Because that gives them flexibility in terms of choices and options around that. And in terms of our commitment to settling invoices within 30 days of receipt for non-NHS creditors, with 96.2% on there, nothing important in terms of cash flow and viability of the suppliers. So, flying under the radar, that's a key indicator for us. In terms of the getting to the year end, so with 41.5 million spent now, that means we need to recover 24 million in the next 3 months. The shape of that is set on the graph on page 4, and we update that graph for the actuals every month. Hitting the control total is not just important for this year, but it's important for next year. If we don't hit the control total, the receipt of 43 million pounds of the recurrent money we've got this year is potentially inbound for next, i.e. keeping the control total as a conditional element in terms of recurrent funding available, which makes it even more important than it was when we were given everything to government script. Page 6 just gives you the breakdown of individual service groups, corporate directors, and then just to advise the board that since the service changes have moved now largely between Morriston and single national targets and primary care, those financial positions now reflect the contemporary position of the organisation. So we need to adjust those numbers because some quite significant steps have moved around our system. So that's there. If I then refer the board on to page 10, the individual elements of the capital landing plan are in there. We risk assessments as part of the formal reporting that we do. Again, not prepared to go through those. We do have the opportunity to make choices, and we work closely with government on the benefits that we get in spending on those, and also sufficient and precious that's managed. And in terms of the cash position, which I know is concerned the board, when we had significant deficit forecast, actually this morning, well, yesterday, but this morning we received a letter from Welsh Government confirming the strategic cash support we'd asked for, which will allow us to meet the requirements at the year end, pay the wage bill and all the other bills to that, which is a significant step forward. It's something that's normal practice, but it's a smaller step. And just in terms of our landing plan, just to give some detail, which we do discuss very detailed level in the Performance and Finance Committee. We, as a board, agreed £24 million worth of actions to close an £18 million gap in the control total. So we had more to go at than we needed. We made a decision, having assessed the planned care recovery slowdown spend, which we'd initially highlighted £3.5 million. We wouldn't cancel any patients committed, and we'd only cancel to vacant capacity scheduled in February, March. First, we'd hope to get £3.5 million from that slowdown spend. It's actually going to be £2.1 million. We are working hard with our service groups and corporate directors to meet the local control total, so we've shared the control total out. Everyone now, with the exception of 2 areas, are committed, confirmed with high levels of assurance they'll meet those control deliverables. Morriston is still working on theirs, it's a 2.5 million gap on which is mental health and learning disabilities of 1 million on theirs. I think there's more movement to come in mental health and that we need to work on with more support. But we've also had some good news in the other direction. Some of the detail which is probably not suitable for public board consumption, but there's some benefits in some of the contracts. And some of the service groups and corporate directors that would exceed the control code of the positive way. So for some mitigation back. So at the moment, we still have a plan which allows us to 70 million. And we've also had some positive feedback from Audit World recently around the proposals around some of the balance sheet areas, and they've confirmed that they can see the logic of the support the approach and the big balance sheet releases that we need to land the plan, which takes an element of risk out as well. So that's probably it in terms of the individual parts, Chair.
Thank you very much indeed, Darren. Questions for Darren? Yes, I think Anna-Louise first.
In terms of the targeted intervention, which relates to planned care, this pinch in the money, will that have an impact on actually getting out of the targeted intervention if we haven't got as much money as we thought to deal with planned care? It sounds a naive question to me as I ask it, but
No, I don't think it is.
It's
a very good question.
It's a very good question. It's a very direct answer, which is spending less on that recovery program will
make it slower.
Impact is more people waiting, not necessarily long, because we are working on the long end of the list step. So the volume will be higher. We've very carefully picked where we've been able to stop, not to impact the longest waiting patients. We've also picked areas where we've got slots available. We haven't committed patients into them, so there's no disappointment or high levels of expectations of patients that have been having operations that we've just cancelled it. So we've certainly not done that, but we'll be doing less operations than we plan to do, hence the financial recovery.
And that will have an impact on our performance against the 104-week target, will it not? Yes, and I think it's important that we are clear about that. It's an invidious choice, isn't it?
Yes.
Yeah.
Yes, so we'll wait and see the detail of the targeted intervention, but it sounds that we're in specific targeted intervention for planned care due to a long wait, so the very long waits that we've got, which are disproportionate to other health boards. They won't be affected by the finance because we will be prioritising those. But as the chair notes, if the detail then comes across the achievement of the ministerial targets in the 104 weeks, then the financial position is likely to impact on our ability to achieve that next year. Because that's the high volume, low complexity work that is more patients rather than the long waits, which are the more complex patients that we don't do.
So we're currently hanging on to that by the skin of our teeth, but it will, yeah. Richard, do you want to come in on that?
Yeah, I think that's a very good question. I think that's, I'm thinking about it in 2 ways, really. The first of those is we yet to see what the metrics are for de-escalating from targeted intervention to enhanced monitoring, how this might factor in, and what we might need to do to reduce that risk and to provide that assurance to Welsh Government. There are choices to be made for next year. And then in terms of what those choices are, if this ends up as a priority in terms of addressing the waiting list, that means that our choices are more limited. We'll have to think differently about how we achieve those things. So I think it may, it's yet to be confirmed, but it may materially impact all the choices that we would have wanted to make and having to revise those in line with delivering next year.
Yeah, thanks, yeah. Darren, I know you want to come back and then I'll come to Nuria.
And it was an excellent point. So we've already committed to spending more than we've allocated. So we've allocated very generously £15.2 million. We plan to spend a lot more than that. We're still going to spend over 6 million more than the plan. Anyway, that's where our resources. So we have committed beyond what was available. And the other thing to Richard's point is part of what this does is it redoubles our efforts to look at the efficiency and productivity of our theatres to eliminate the need for sourcing. I can't invent a productivity and efficiency in this instance. I wouldn't want to, but we need to make the plans that we've got as hard as possible.
Nuria, question.
I just wanted to find out more about mental health and learning disabilities. It says that it's got an overspend of 336,000 so far this year, and it looks like 290,000. It's in table 4, Darren. it looks like the majority of that was in month 9. So I was just wondering what the story was there, whether there is any underlying pressure that will have implications for the remainder of the year.
The two elements driving mental health, sorry, Chair.
Mm-hmm.
The two elements driving mental health performance. One is continuing healthcare, and those assessments are made routinely every month. So that's the most volatile part of it.
Yeah.
It can change by hundreds of thousands each month, which is very good. And the other one is there's been an increase in agency staffing, in particular mental health and LD. So as we address pressures on the acute side, which we've done really, really well, and we've really positive inroads by reducing agency spend by over £1.5 million a month. In mental health and LD, we're seeing some recruitment challenges, and I know the International Nurse Recruitment will focus on that, but also an increase in patient acuity requiring more one-to-one nursing as well.
Okay.
So there's an acuity of care point, the recruitment point, and we'll address the recruitment through the plans. We go to an management board of me.
Can I just ask another question, which is more around assurance on the whisker element of recovery of underperformance, and just in particular, I think it's that assurance that it won't impact on the usual process of treat in turn, clinical prioritization of our waiting list, etc., regardless of the funding source.
So we don't interfere with the finances who decisions run the clinical process. The clinical process runs, the operational processes run. Patients are appointed in accordance with those processes. What we're seeing in the dynamic of WISC is a change in contract mix from cardiac surgery to TAVI procedures. That's showing an under recovery significantly on the cardiac surgery line, and over recovery on the TAVI line. There's an imbalance in that. And there are proposals, which we've gone through this yesterday, the chief executive was at that meeting, looking to rebalance those contracts sensibly and in a stepwise way over the next few years. Not just for significant resource out in cardiac surgery and then we'll over so, but the mix of the contract, we're on to that, but the patient appointing the operational processes aren't the best.
So there was a long discussion at WISC yesterday, because really this needs a strategic response, because Cardiff is in exactly the same position, and Cardiff laboured the point yesterday that we need to look at this in a strategic way with that service. So because it potentially gives us a significant reduction in income, essentially, potentially. The way we're managing it for next year covers that off. But obviously we've got stranded costs as a result for reductions in activity levels.
So I've got Deb and then Darren and then Steve.
It's just important though for cardiac surgery, the reduction in activity levels was due to reduction in demand,
Yeah.
not to us doing less.
Yeah.
It's taken this long to feed through because we were looking to see whether referrals into cardiac surgery recovered post-COVID, and they just haven't, and they haven't for us, and they haven't for Cardiff Centre either. So it is that balance now of, you know, how much do we need to sustain an emergency service for which the demand is still high, but TAVI seems to be taken over from routine cardiac surgery that we would be doing pre-COVID. So it's not that we're not able to do the activity, it's just the activity isn't there for us to do at the moment.
It's not particularly well understood.
Because interventional hence the need for a strategic solution.
Yeah.
Interventional cardiology is replacing cardiac surgery, so interventions are getting less and less, and therefore we need to look at it as a service strategy as opposed to something that is just something that's happening to us. We've got to be careful that there isn't an untapped demand, so unmet demand. So because our surgeons are saying there is still a level coming through, but we'll need to look at that in terms of what the population base is telling us. It's in exactly the same position in Cardiff. Hence, we need to have a discussion really.
Thank you. Thanks, Nuria.
Very briefly, just to touch on some of the machinery of the WISC contract. So for every £1 million investment in cardiac, we get 400,000 back.
Yes, that's true.
Works.
Yeah.
So the finances are more opaque than an underspend on income. It's got an income list to provide a contract and then it's washed back. So we've got eyes on it, but it's not as stark as it would appear just in terms of the volume, as there are other benefits elsewhere in the system. We just need to treat the right patients in the right.
Thank you, Darren. Interesting conversation. Steve.
Yeah, the next financial year is upon us in 8 weeks' time. And I know you're working on a financial plan for next year, and that we all know that there's not going to be any more money, even less money around next year than this. The accountable officer's letter, I think, is due in a couple of weeks' time on the 16th of February. So just could you explain to the board what oversight we will have over the content of that letter and the plan as it develops up till the beginning of the new year?
So, to date, we've had an informal discussion, executive team, about the shape of the plan. Also, Finance Committee had an in-committee session last week. A lot of the deeper the composition of hesitating to put in the plan. It's a financial assessment. There's lots of moving parts. The next steps are that I'll be presenting a version, almost exactly the same actually, of what Performance Committee, Performance Committee saw to Welsh Government and their executive on Monday. And then we'll take feedback from that, and then I will feature another presentation on the 13th of February to the board briefing. So I think we've agreed between the executive too, as well as independent board members, which will have a more granular picture of the plan at that stage, and that will enable us to determine whether is required. At this stage, I believe it will be, so we've started to draft that. The broad message from that accountable officer letter will be that at this stage in our planning, we have not yet identified a plan which achieves the requirements. We are continuing to make these steps with colleagues in government and areas through the rest of that process. March.
Thank you.
And my understanding is the Performance and Finance Committee were concerned about the current gap. I think we will be looking at that 13th of February, if not before, for evidence that we have gone wherever we need to go, and that the really difficult decisions have been thought about. Accepting the unacceptable.
Refreshing that. We're also looking for new opportunities through my program savings office and looking at that to benchmark nationally white see what very actually cash to that target. And there'll be a balance and the plan that we make.
I think what's important tonight is the conversation we had about the benchmarking of budget. Because obviously we've got very significant run rates issues in certain areas that are recurrent ongoing. So it's quite important that we challenge the budgets or rebase them. And I know that there are plans put to do that in a manageable way, because that's a huge exercise. But it's critical, I think, that when we're asking for savings, that we know certain areas have got realistic, robust start budgets to work from.
Okay. Thank you, Richard.
Well, very little footnote to the discussion on cardiac surgery. It might be particularly informed by our local experience, and that's just about the fixed costs. So although we will have part of the challenge of that and potentially money coming out of cardiac surgery is that we have fixed costs. Board members will recall that part of the issue around the cardiac surgical review that we had a couple of years ago was that there was expertise required, particularly in valve replacement surgery, and that for mitral valve surgery, that those should be consultants who are specialised in mitral and replacing mitral valves, whether they be single valves or more than one valve, one of which would be the mitral. So it means that our cardiac surgical workforce isn't generic amongst the surgeons. It's not just people who can do valves and do bypass operations. There's a particular skill set that you need amongst the surgeons. And of course, there's a critical mass as well that you need in order to provide continuity and cross cover. So it does present an interesting challenge for us about how that comes out, because there will be an infrastructure that will be required as a baseline in order to deliver that service, regardless of the numbers that come through. I hope that makes sense.
Thank you. Thank you very much. Okay, let's move to the performance report.
Yeah, sorry, yes, just before we move on to that, there was one question I had, which was, have we had any response from Welsh Government on the 6 million capital funding for cyber?
Thank you, Jean. Matt?
We have put a further proposal forward. Positively, we wait for the minister to approve our proposal for 638K. So we're in a better place than where we were last time we spoke.
Thank you. All right, thank you. So yes, just to recap on the finance, we have a landing plan which we are hovering towards. But there are considerable concerns, frankly, about next year. But there is an enormous amount of work going on. I think that is a very brief summary of the situation.
I think for me to just add that for next year, that our Welsh Government NHS colleagues have worked really hard to get a lot of money into health.
Yeah.
So as there are challenges next year, the settlement is considerably better than anticipated.
Yeah.
Hence the need for us to call to arms really. They work hard on their fair. We need to meet that challenge well.
And also in terms of our partners who have, you know, some of the local authorities do not have some of the flexibilities we have and are equally pressed. And it behoves us to play our part in making sure that we do make the most of what we've been given. Thank you. Okay, performance report.
I can take this, Chair.
Yeah,
Okay,
thank you.
And what I'll do today is, given we've had a conversation with target intervention,
Yeah.
go through those areas for now.
Yeah, that would be very helpful. Thank you.
So page 11 of the report sets out the unscheduled care aspect of our performance and the 4-hour target. We've always performed well against this target. We were 75.3 in December, and it looks like we're at a similar level, which I think based on figures I've seen today, was slightly off profile because we're in an improving trajectory in terms of national comparables. That's at the higher end. I know we would aspire to be higher, so we're not clearly complacency here, but it's good. In terms of 12-hour waits, which is the bottom of that page, we had a step to drop in November and December to the 900s. It looks like we're between 900 and 1,000 again. Over the page, ambulance lost thousands will be a very key focus of TI activities. You can see there the number of ambulances waited over 4 hours, which has been consistently in the 300 to 400 region. Just for clarity, the target's 15 minutes. This is the measurable line. And beneath that, the number of hours lost due to ambulance delays, which if you look at 3,500 to 4,000, that's considerable resource on our four groups. Page 13 sets of cancer. We were 53% in November. Excuse me. And the backlog at the moment is 292, which is slightly better than 302 reported. 16 in gynecology, 56 in urology, 52 in lower GI, 32 in GI, 25 in. I need to get through this without losing my voice. Let's get that. Page 17 is ambulance response times for red calls, 47% in December, 51% now. This is part of the urgent emergency care dynamic. And how do I'll just then take us to planned care. On page 30, again, the area where we've been escalated. The sleep graph 2 on page 30 shows the number of patients waiting over 52 weeks for first outpatient appointment. We achieved 0 in October, and we continue to work below that. We were the first health board in us to do that, and we are excelling in that area, which means that our patients have consultation and potential diagnostics earlier than they would have, which will give them assurance, allow us to plan treatment from there on. Where we have had challenge, and we have discussed this, graph 4 shows the number of patients waiting over 104 weeks for surgery. Well, it's all pathways, but largely it's surgery. We have seen steady and significant improvement there. If you go back to the 30 months, we would aspire to continue to do so. And we'll just assess the impact of industrial action and the modest curtailment of spend on that. The target at the end of March is 99% of patients waiting under 4 weeks. And currently we're a bit shy of that, but we'll probably draw that out in conversation as well. Diagnostics and therapies are on page 32. I won't go into those in detail until we know whether they will be part of TI, but they're around planned care. Our therapy rates are the best in Wales, and actually our diagnostic numbers are, but we have significant numbers that we're working hard to get below 8 weeks. Those are the main areas in terms of TI. I think just importantly, and this is now a consistent service change and improvement, if I refer the board to page 38, where child and adolescent mental health performance is reported. You'll see there, particularly around CAMS, patients waiting for therapeutic intervention and assessment since August. step change in progression and the access to care that was really important to the vulnerable patients in our community. So just
That
wanted
is
to-
the best performance I think I've seen in a very long time, if throughout my time, actually. I think I'm really, really delighted to see that.
And we've been waiting some time with some confidence to see that come through, but it's worth remarking now, given that it's been a number of months for that performance. Lots of other things in there. I'd probably stop there, Chair, given the focus of the conversation today.
Thank you very much, Darren. Deb, is there anything you wanted to say sort of overall before I open it up?
Yeah, I think so, Chair. So it is disappointing that we're in targeted intervention in some areas and probably unsurprising in others. So it's looking at the balance of where we are. Unscheduled care, we know the main focus for us is reducing those ambulance delays at the front door, and that's been a prime focus of us, particularly over the last 12 months. We made some good inroads into reducing the very long waits. It slipped a little bit due to the winter pressures. We've got to absolutely get back on track and bring those reductions in line with where we want to be, and get down where we want to be quickly is nothing over 4 hours outside the door as we bring the waits down accordingly. Planned care, I think, as Darren notes, important to note that we are leading the way in some of the planned care measures, but it's the very long waits that we've got to address. Okay, we have given the commitment the long waits are only those waiting for treatment. So reducing our first outpatient appointments in the way we have gives patients assurance and access to treatment where it's not surgery, and then we know what we've got to do from a surgical perspective and how we balance that. We're leading the way in diagnostics and in therapy delivery, other than endoscopy from an endoscopy from a diagnostic perspective. So there's some good work and we're doing, and we can be very proud of where we're going in some areas. And I think we've got robust plans, particularly in the planned care world, for where we're going next year. But we can't shy away from where we've got the challenges, and I think that's got to be our focus, particularly for cancer. So we've seen a little bit of an improvement for cancer, but it's very static. Our focus is going to be to reduce the front end of the cancer pathways. Again, give assurance to patients where they can have it, and have a treatment plan early doors for patients who need to go on for curative surgical treatment in particular. So we're making inroads into that. We wanted the stage 1, so the first outpatient wait for cancer targeted around 10 days if it's an outpatient appointment, or 21 days if it's what we call a one-stop shop where you have your diagnostics at the same time. We've made improvements in that leading up to the end of December. We are struggling with patients who make choices not to attend. So we are shifting some of that focus to communications with primary care and GPs in particular, to make sure patients are aware of the urgency of the appointment they're being referred in for. We're not an outlier there, so feedback from Welsh Government is that other health boards are seeing that pattern as well. Previously, within the cancer realm, you could reduce the wait by the period of unavailability for patients. Since we brought the single cancer pathway in, it's now a continuous wait. And unless it's more than 6 weeks, you don't change that pathway. So literally a patient can make themselves unavailable for 6 weeks on a 62-day pathway, and there's nothing we can do about that. We've just got to absorb that and do the best we can. That is acknowledged in the target. It's a 75% target, but it has a big impact on our delivery. So we're focusing on that area as well. So I think within the targeted intervention realm, there's good news for us as a health board, as well as we really do understand the challenges that we've got, and we're upfront with them. You know, they've been visible to the board certainly since I've been in post, and we know what we've got to do with them. Thank you. That's very helpful there. Raj?
No, just to add on what Deb has actually been saying is the fact that there's been from the team, the transformation team, which Deb is leading, there's actually been additional input being put into the cancer services. We're also having fortnightly cancer escalation meetings, which includes the lead and either the COO or the deputy COO is actually part of that too. So that's happening. And there is actually a recovery and improvement plans for each tumor site. So the fact that even though some of these meetings are monthly, there are weekly meetings for the specific tumor sites just to see how that's actually going on. The issues we have, the challenging sites are actually gynae oncology, as we have mentioned before, urology and lower GI. Again, to say that the fact that the recent figures from lower GI is actually much better than before too. Gynae oncology, the shift has been, even though the numbers are actually not what we would like to see, is the shift has been the waiting list initiative we actually started on for a Saturday, and that's actually made a significant improvement with regards to that. With regards to urology, the robotic the business case actually been approved, so that the fact that some of the urology cases were actually going to Cardiff and Vale, so that's being renegotiated as to whether they could actually come to here.
And also previously we had significant problems with regards to dermatology, but that's again been addressed significantly, especially with primary care input, and we are making sure that the slots there are actually being exploited too. Breast was another area. Previously, we did struggle. Again, there has been appointments for the breast surgeons, and so that's actually we'll be having 2 new colleagues actually be starting now. And also the Cancer Performance Improvement Group has been re-established, so that will be an oversight from a corporate level too, just to see how things are going on.
Thank you. Very helpful indeed. Thank you. Questions? Louise?
Could we ask for some more information about the endoscopy weights? Because looking at the graph, the figures have been pretty static for the last 3, October, November, December. And it's mentioned in your report, Richard, that there's an action plan. And on the report, it says that in compliance with the ministerial target, the ministerial target is 0 by March 24. And 3,553 sounds an awful lot to get through in the next 8 weeks. And I just wondered what the plan actually is. Thank you.
I can respond to that.
Sounds like midnight working.
It's been a focus of us for a long time. I think as a health board, we put an awful lot of additional resource into endoscopy. And we have to acknowledge we've not seen the benefit that we wanted to see through that investment. We are on our trajectory. So we submitted a recovery trajectory, which wouldn't get to 0, but showed a plan and reduction in those patients 3 to 8 weeks. And we've been there or thereabouts on that plan, but it's still not giving us where we want to be and where we need to be as part of that. So I've commissioned a piece of work going into Q1, particularly to look at endoscopy. So the board will be aware of, we've got Rob Royce, who's been with us for a little while in supporting in some of the planned care and AMSR work we've done. He was due to leave us at the end of March, but I've asked him to stay on just for Q1 with focus on specifically endoscopy for us. And a couple of areas in that, we need to understand where our core budget is going in endoscopy, and therefore how far off from it, if we didn't have a backlog, could we achieve today's work today with what we've got in our core budget? And if not, what does that sustainable investment need to look like? And we can build the case for what that looks like. And then to look at the backlog reduction, so we've got clarity of how quickly we can achieve what we need to achieve. On a positive note, we've reduced the cancer weights in endoscopy, and we've sustained that, which has been that was always our priority to do. And then we want to bring the urgent cohort into a realistic waiting list as well at the moment. So board will be aware that, you know, our single cancer pathway referrals for endoscopy rose because it was either seen as a single cancer pathway patient or wait 18 months for your diagnostic, and there was nothing in between. So we've now got to bring an urgent wait in, which would probably be about 12 weeks in the first instance, to say, right, now we understand the demand for cancer, we understand the urgency bit, and then we need a plan for routine. So that's the plan for us going into Q1, to develop that recovery plan. And alongside that, obviously, there's the regional work that we're doing with ourselves and how do we work as a system to increase the capacity that we need in endoscopy. Some of that, I think, will be demand management rather than additional capacity as well, to make sure we've got the right patients coming in and managing that demand in the right way. So we know that we've not recovered as we want to do an endoscopy. That's why we've commissioned a focus piece going into Q1.
Okay, so presumably then you'll be able to have a better idea of when you will actually achieve that kind of balance picture.
I mean, for us as a board, we need to know what we need to be doing in endoscopy.
Yes.
What does that service need to look like? Because it obviously is not looking like it needs to look like at the moment, because the backlog has grown. If we took the additional investment we've put in, the backlog would still be growing. So we know that the core service, we need to identify what that needs to look like first. Then we need to know what we need to commission as a board for that service, and then we can look at the backlog and move on alongside that.
Thank you.
Helpful. Thank you. Dan.
You just said it's a practical point, and recognise that this performance report we gather for an organisation that's not in this level of escalation. And it might be helpful to be future iterations of the report to draw out the very front. These are the indicators, as the clarity comes forward, these indicators we now know are the ones we need to track for the escalation purposes. But still bring the weight of all the rest, because it gives a picture of relative from a TI perspective. My assessment is this doesn't really do the job for scrutiny, and I'll make some adjustments with the board's permission for the next report and then to just highlight the TI elements.
You've preempted our thoughts on that actually, Darren, but I think that would be helpful. Good. Any other? Yes, Gareth.
I should know this, so bear with me. In terms of Welsh Government support in terms of sort of structural oversight for TI? Have we had any confirmation of anything centrally to help us take this forward?
We've had one piece of correspondence asking us to have a key individual to do that work with Welsh Government to identify the relationships and how the structures of reporting and the formality of that.
I'm assuming that we'll get that when we have our meeting that we're going to have with the board and Welsh Government around the arrangements. Yeah, I think that would be quite helpful so that the board understands both the expectations, the de-escalation, the framework, and indeed the support.
Which is implicit in the escalation itself.
Yeah, I think that'd be very helpful indeed. Good. Okay, I think we've now reached the end of the performance section. We have, so I am going to propose that we are on time, in fact, that we take half an hour lunch break, and that we reconvene at 1 o'clock. Thank you all very much.